Rapid review, first aid. This is STEP1 2025 edition, 35th edition. Condition Lish-Nyhan syndrome. Defect in HGPRT increases de novo purine synthesis and increases uric acid production. What is Lynch syndrome? HNPCC. Lynch syndrome is mutation of MMR gene, MLH1, MSH2, which leads to failure of mismatch repair during the S phase, which leads to microsatellite instability, causing colorectal carcinoma in 80% population. Beta thalassemia causes mutation at splice site or promoter sequence on chromosome 11, which leads to decrease or absent beta globin synthesis. What is osteogenesis imperfecta? Mutation in COL1A1 and COL1A2 genes. Type 1 collagen defect, inability to form triple helices. What is Ehlers-Danlos syndrome? Ehlers-Danlos means faulty collagen synthesis, hyperextensible skin, hypermobile joints, easy bruising. Patient typically presents with aneurysms. What is Menkes disease? Defective ATP7A protein, impaired copper absorption and transport, which leads to decreased lysyl oxidase activity, decreased collagen cross-linking. What is Marfan syndrome? Marfan syndrome is FBN1 mutation on chromosome 15. Defective fibrillin 1 glycoprotein normally forms sheath around elastin, but in Marfan that is absent, that is defective. So there is no sheath around elastin. What is Prader-Willi syndrome? Prader-Willi means imprinting or maternal uniparental disomy in 25% people, deletion or mutated expression of paternal allele on chromosome 15. What is Angelman syndrome? Angelman means imprinting or paternal uniparental disomy 5%, deletion or mutated expression of UBE3A on maternal chromosome 15. What is cystic fibrosis? Cystic fibrosis, delta F508 deletion in CFTR gene on chromosome 7, impaired ATP-gated chloride channel, which leads to impaired secretion of chloride in lungs, GI tract, and reabsorption of chloride in sweat glands. Next, Duchenne muscular dystrophy, dystrophin gene frameshift or nonsense mutations, which leads to loss of anchoring protein to ECM dystrophin myonecrosis. What is Becker muscular dystrophy? Becker muscular dystrophy is non-frameshift deletion of dystrophin gene, and it is also less severe than Duchenne. D for Duchenne, D for die. So Duchenne is severe form, Becker is benign form. Myotonic dystrophy, CTG trinucleotide repeat expansion in DMPK gene leads to abnormal expression of myotonin protein kinase, which leads to myotonia. What is Fragile X syndrome? Fragile X syndrome is CGG trinucleotide repeat in FMR1 gene, hypermethylation of cytosine, residues, decrease expression. What is whiteout spots in vitamin A deficiency? In vitamin A deficiency, you see decreased differentiation of epithelial cells into specialized tissue. This leads to conjunctival squamous metaplasia, leading to keratin build up. Next is Wernicke encephalopathy in patients with alcohol use disorder given glucose. In alcohol use disorder, first you give B1. First you give thiamine deficiency. You give thiamine for thiamine deficiency. So Wernicke encephalopathy happens when you give glucose before giving thiamine. So thiamine deficiency leads to impaired glucose breakdown. This leads to ATP depletion worsened by glucose infusion. Next, pellagra in malignant carcinoid syndrome. This is tryptophan is diverted towards serotonin synthesis by tumor. B3 deficiency. B3 is derived from tryptophan. What is Kwashiorkor? Kwashiorkor is protein malnutrition, decreased plasma oncotic pressure. This leads to edema, decreased apolipoprotein synthesis, which leads to fatty changes in the liver. What is lactic acidosis? Fasting hypoglycemia, hepatic steatosis in patient with alcohol use disorder. Lactic acidosis is caused by increased NADH/NAD plus ratio due to ethanol metabolism. When you have increased ratio of NADH/NAD plus due to ethanol metabolism, you see lactic acidosis. You also see fasting hypoglycemia, hepatic steatosis in patients with alcohol use disorder. Next, what is aspirin-induced hyperthermia? In aspirin-induced hyperthermia, you have increased permeability of inner mitochondrial membrane, decreased proton gradient, and increased O2 consumption, which is uncoupling. Increased O2 consumption via uncoupling leads to heat production. So in aspirin-induced hyperthermia, you see increased permeability of inner mitochondrial membrane, decreased protein gradient, and increased O2 consumption, which is uncoupling, leads to heat production. What is hereditary fructose intolerance? Hereditary fructose intolerance is aldolase B deficiency, which leads to fructose 1-phosphate accumulation. This leads to decreased available phosphate, which causes inhibition of glycogenolysis and gluconeogenesis. What is essential fructosuria? Essential fructosuria means fructokinase deficiency leads to increased fructose. Hexokinase pathway converts fructose to fructose 6-phosphate. What is classic galactosemia? Galactose 1-phosphate uridyl transferase deficiency leads to accumulation of toxic substances like galactitol in eye lens, causing cataracts. What is galactokinase deficiency? Galactokinase deficiency leads to increased galactose. Aldose reductase converts galactose to galactitol. Next condition you see cataract, retinopathy, nephropathy, peripheral neuropathy in diabetes mellitus. These conditions are because of excess glucose, which converts to sorbitol via aldose reductase and sorbitol. This leads to fructose via sorbitol dehydrogenase. Lens, retina, kidney, Schwann cells lack sorbitol dehydrogenase. This leads to intracellular sorbitol accumulation, osmotic damage. Recurrent Neisseria bacteremia. Recurrent Neisseria bacteremia is due to terminal complement deficiency C5C9, failure of MAC formation. This is the main reason for recurrent Neisseria bacteremia. Hereditary angioedema is due to C1 inhibitor deficiency, which leads to unregulated activation of kallikrein. This leads to increased bradykinin. What is paroxysmal nocturnal hemoglobinuria? Short form is PNH. Paroxysmal nocturnal hemoglobinuria is due to PIGA gene mutation. PIGA gene mutation. decreased GPI anchors for complement inhibitors. Decreased GPI anchors for complement inhibitors. It is also known as DAF/CD55 and MIRL/CD59 gene, complement mediated intravascular hemolysis. So, paroxysmal nocturnal hemoglobinuria main reason is complement mediated intravascular hemolysis. This causes decrease in haptoglobin. Whenever there is hemolysis, you see a decrease in haptoglobin. What is type 1 hypersensitivity? Type 1 hypersensitivity is immediate, which means in minutes, causes antigen cross-links IgE on mast cells, degranulation, which leads to release of histamine, tryptase, leukotriene, HTL. Histamine, tryptase, and leukotriene. This is immediate reaction. Type 1 hypersensitivity late, which you will see in hours, is due to mast cells that secrete chemokines and they attract inflammatory cells and other mediators. This leads to inflammation, tissue damage. What is type 2 hypersensitivity? Type 2 hypersensitivity is antibodies bind to cell surface antigens or ECM, inflammation, cellular destruction, and dysfunction. Type 2 hypersensitivity causes antibody to bind cell surface antigen or extracellular membrane ECM, which leads to 4 changes. One is inflammation, then second is cellular destruction and dysfunction. So 3 changes: inflammation, cellular destruction, and dysfunction. What is type 3 hypersensitivity? Type 3 hypersensitivity is antigen antibody complexes activate complement. So in type 3 hypersensitivity, you see antigen antibody complexes activate complement. This leads to attract neutrophils, which leads to release of lysosomal enzymes. What is type 4 hypersensitivity? Type 4 hypersensitivity is T cell mediated, no antibodies involved. They have APC activation with CD4 plus T cells. This release of cytokines or CD8 plus T cells leads to direct cell cytotoxicity. So type 4, there is no antibodies involved. There is only T cell mediated functioning, and APCs activate CD4 T cells. This release cytokines or CD8 plus T cells that release direct cell cytotoxicity. Next condition is acute hemolytic transfusion reaction. This is a type 2 hypersensitivity reaction against donor RBCs, usually ABO antigens. X-linked Bruton agammaglobulinemia is defect in BTK gene. This leads to no B cell maturation, which causes absent B cells in peripheral blood, and therefore you see decreased immunoglobulin of all classes. Agammaglobulinemia, immunoglobulin of all classes are depleted, and this is because of defect in BTK gene. Next condition is DiGeorge syndrome. DiGeorge is 22q11 microdeletion. This is because of failure to develop third and fourth bronchial pharyngeal pouches. This leads to absent thymus and parathyroid. Hyper IgM syndrome, defective CD40 ligand on TH cells, leads to class switching defect. What is leukocyte adhesion deficiency? Type 1, leukocyte adhesion deficiency type 1 is LFA1 integrin CD18 defect, causing impaired phagocyte migration and chemotaxis. What is Shidiak-Higashi syndrome? Shidiak-Higashi syndrome is List mutation causing microtubule dysfunction, phagosome-lysosome fusion defect. What is chronic granulomatous disease, CGD? CGD is NADPH oxidase defect. This leads to decreased reactive oxygen species, which leads to decreased respiratory burst in neutrophils, causing increased susceptibility to catalase-positive organism. What is Candida infection in immunodeficiency? Candida infection in immunodeficiency is decreased granulocytes, which is in systemic infection, decreased T cells in local infection. What is graft versus host disease? GVHD. So 4-letter word, that's why it is type 4 hypersensitivity reaction. It is because of HLA mismatch causing donor T cells attack host cells. Next is recurrent S. aureus serratia B. cepacia infection in CGD. These are all catalase positive organism. So catalase positive organism degrade H2O2 before it can be converted to microbicidal products by myeloperoxidase system. Next is hemolytic uremic syndrome, HUS. Hemolytic uremic syndrome is Shiga-like toxins inactivate 60S ribosome, which causes increased cytokine release. What is tetanus? Tetanus is when tetanospasmin cleaves snare. This leads to inhibition of release of inhibitory neurotransmitters like GABA and glycine from Renshaw cells. So once again, tetanus is tetanospasmin cleaves snare. Inhibition of release of inhibitory neurotransmitters causes from Renshaw cells, which are the inhibitory neurotransmitters. Those are GABA and glycine. So next, very similar mechanism but different is botulism. Botulism is toxin, which is protease. So protease toxin cleaves snare, decreases neurotransmitter acetylcholine release at neuromuscular junction. What is gas gangrene? Gas gangrene is alpha toxin, a phospholipase / lecithinase degrades phospholipids, which leads to myonecrosis and crepitus. What is toxic shock syndrome and scarlet fever? TSST1 and erythrogenic exotoxin A cross-link beta region of TCR to MHC. Class 2 on APCs outside of antigen binding sites, which leads to increase interleukin 1, interleukin 2 and interferon gamma, TNF alpha. Toxic shock syndrome, scarlet fever, is due to TSST1 and erythrogenic exotoxin A that cross-link beta region of TSR to MHC class 2 on APCs outside of antigen binding site. This leads to interleukin 1, interleukin 2, interferon gamma and TNF alpha release. What is shock and DIC caused by gram-negative bacteria? Lipid A of LPS macrophage activation, which is TLR4-CD14, causing complement activation, tissue factor activation. This is shock and DIC caused by gram-negative bacteria. Because they are gram-negative, they have lipid A and LPS macrophage activation and complement activation. Next condition is prosthetic device infection by S. epidermidis. Prosthetic device infection by S. epidermidis. Mainly biofilm production around the prosthetic device causes infection. Next condition is endocarditis secondary to S. sanguinis. This is because of dextrans biofilm production. Fibrin platelet aggregate bind to damaged heart valves. This is what causes endocarditis. So in endocarditis, you have fibrin platelet aggregate binding to damaged heart walls. Next is pseudomembrane colitis secondary to C. diff. Toxin A and B damage enterocytes causing watery diarrhea. Next condition is diphtheria. Diphtheria is caused by exotoxin when it inhibits protein synthesis via ADP ribosylation of EF2, leading to possible necrosis. What is virulence of M. tuberculosis? Virulence of Mycobacterium tuberculosis is caused by cord factor activates macrophage, promoting granuloma formation, induces release of TNF alpha, sulfatides, surface glycolipids, inhibit phagolysosomal fusion. What is tuberculoid leprosy? Tuberculoid leprosy is caused by Th1 immune response. This is a mild symptom. What is lepromatous leprosy? Lepromatous is Th2 response mediated and this can be lethal. Lack of effective vaccine for Neisseria gonorrhea is because of antigen variation of pilus protein. This is what causes lack of effective vaccine for Neisseria gonorrhea. What is cystitis and pyelonephritis secondary to E. coli? What causes cystitis and pyelonephritis secondary to E. coli? Fimbriae P. pili causes cystitis and pyelonephritis. Next condition would be pneumonia, neonatal meningitis secondary to E. coli. So K capsule causes pneumonia, neonatal meningitis secondary to E. coli. Chlamydia resistance to beta-lactam antibiotics. So what causes chlamydia resistant to beta-lactam antibiotics? Lack of classic peptidoglycan due to reduced muramic acid. Lack of classic peptidoglycan due to reduced muramic acid causes chlamydia resistance to beta-lactam antibiotics. What causes influenza pandemic? Influenza pandemic is caused by RNA segment resortment, which causes antigenic shift. Main mechanism is antigenic shift. Next is influenza epidemics. Influenza pandemic is because of antigenic shift. Epidemic is antigenic drift. Influenza pandemic is antigenic shift. Epidemic is drift. Mutation in hemagglutinin neuraminidase causes antigenic drift. Next condition is CNS invasion by rabies. Rabies binds to acetylcholine receptors, which lead to retrograde transportdynin. So this is what causes CNS invasion by rabies when it binds to acetylcholine receptor, causing retrograde transportdynin. Next condition is HIV infection. HIV infection binds CD4 along with CCR5 on macrophages early or CCR4 on T cells late. Next condition, what causes granuloma? Granuloma is caused by macrophages present antigen to CD4 plus and secrete interleukin 12, which causes CD4 plus release, differentiation into Th1, interferon gamma secretion, and macrophage activation. Once again, what causes granuloma? Granuloma is caused by macrophages presenting antigens to CD4 plus and secrete interleukin 12. This leads to CD4 plus differentiation into Th1, interferon gamma secretion, which leads to macrophage activation. What is limitless replicative potential of cancer cells? This is reactivation of telomerase, which leads to maintaining and lengthening telomeres. This leads to prevention of chromosome shortening and aging. So limitless replicative potential of cancer cells is caused by reactivation of telomerase. This leads to maintenance and lengthening of telomerase. This leads to prevention of chromosome shortening and aging. What causes tissue invasion by cancer? Tissue invasion by cancer is due to decreased E-cadherin function. This leads to decreased intracellular junction. This leads to basement membrane and extracellular membrane degradation by metalloproteinases. This leads to cell attachment to extracellular membrane, ECM protein, laminin, fibronectin. Then you see locomotion. Then you see vascular dissemination. This is the mechanism. So once again, tissue invasion by cancer, you have E-cadherin function leads to decreased intracellular junctions. This leads to basement membrane and ECM degradation by metalloproteinases. This leads to cell attachment by ECM protein. This leads to laminin, fibronectin, locomotion, and vascular dissemination. Next would be persistent truncus arteriosus. What causes persistent truncus arteriosus? Failure of aorticopulmonar septum formation. Next condition is detransposition of great arteries. This is because of failure of aorticopulmonary septum to spiral. Detransposition of great arteries is due to failure of aorticopulmonary septum to spiral. Then we have TET spells in tetralogy of Fowler. You see mainly crying, fever, and exercise that increases right ventricular volume, right ventricular outflow obstruction. This leads to increased right to left flow across VSD. So again, TET spell in tetralogy of Fallot is crying, fever, exercise, which leads to increased right ventricular outflow obstruction. This leads to right to left flow across VSD. Next is Eisenmenger syndrome. Eisenmenger is uncorrected left to right shunt, increasing pulmonary blood flow. So when LR shunt is not corrected, it leads to increased pulmonary blood flow. Increased pulmonary blood flow will cause remodeling of vasculature. This will cause pulmonary hypertension. This will cause right ventricular hypertrophy, eventually leading to right to left shunt. So initially there is left to right shunt, and then you have increased remodeling vasculature causing pulmonary hypertension, right ventricular hypertrophy. This causes right to left shunt. Next condition is atherosclerosis, which is endothelial cell dysfunction causing macrophage and LDL accumulation, causing foam cell formation, which leads to fatty streaks, smooth muscle cell migration, ECM deposition, fibrous plaque, and complex atheromas. Next condition is thoracic aortic aneurysm. Thoracic aortic aneurysm is caused by cystic medial degeneration associated with tertiary syphilis. What is myocardial infarction? Rupture of coronary artery atherosclerotic plaque causes acute thrombosis. What is NSTEMI? NSTEMI is subendocardial infarct. STEMI is transmural infarct. So STEMI is transmural infarct. NSTEMI is subendocardial infarct. Death within 0 to 24 hours post MI is because of ventricular arrhythmia. So ventricular arrhythmia can cause death within 24 hours. Death or shock within 3 to 14 days is caused by macrophage mediated ruptures like papillary muscle rupture, which is in 2 to 7 days, interventricular septum 3 to 5 days, free wall rupture is between 5 to 14 days. So once again, death or shock within 3 to 14 days post MI. So papillary muscle rupture you see in 2 to 7 days. Interventricular septum rupture you see in 3 to 5 days. Free wall rupture you see in 5 to 14 days. Next is Wolff-Parkinson White syndrome. WPW syndrome. This is abnormal accessory pathway from atria to ventricle, bypasses the AV node, which leads to ventricles begin to partially depolarize earlier. That leads to delta wave formation, causing re-entrant circuit, which is also called supraventricular tachycardia. Basically, you're bypassing AV node, and so the pathway is causing early depolarization, which makes the delta wave, and this delta wave is seen on EKG, which is also seen as supraventricular tachycardia. Next condition is hypertrophic obstructive cardiomyopathy, HOCM, HOCM. Hypertrophic obstructive cardiomyopathy is caused by sarcomere protein gene mutation. This is caused by concentric hypertrophy, sarcomeres added in parallel. Death is due to arrhythmia. HOCM, hypertrophic obstructive cardiomyopathy, is usually seen in young, mostly like basketball players, African American. They have no history of cardiac issues before they were playing the basketball match. However, all of a sudden they have syncope and they fall on the ground and they collapse. That is typical sign of HOCM, hypertrophic obstructive cardiomyopathy. This is because the sarcomeres are added in parallel. Death is always due to arrhythmia. Next is syncope dyspnea in HOCM. When you see syncope and dyspnea in hypertrophic obstructive cardiomyopathy, that is because of asymmetric septal hypertrophy and systolic anterior motion of mitral valve causing outflow obstruction. What causes hypovolemic shock? Next condition is hypovolemic shock. Hypovolemic shock is decreased preload, which leads to decreased stroke volume, and this leads to decrease in cardiac output. So decreased preload causes decreased stroke volume, decreased cardiac output. What causes cardiogenic shock? Cardiogenic shock is because of decreased cardiac output. Cardiogenic shock, decreased cardiac output due to left heart dysfunction. What is obstructive shock? Obstructive shock is decreased cardiac output due to blockage of vessel structure outside the heart. What is distributive shock? Distributive shock is decreased systemic vascular resistance after load. After load, what is after load? After load is the resistance offered by the stroke volume on the aortic root. So that is after load. Decreased systemic vascular resistance is seen in distributive shock. What is rheumatic fever? Rheumatic fever happens when you see antibodies to M protein cross-react with self-antigens. It's a type 2 hypersensitivity reaction. Next condition, deep vein thrombosis, DVT, is stasis, hypercoagulability, endothelial damage. This triad is called Virchow's triad: stasis, hypercoagulability, and endothelial damage. This leads to blood clot with deep vein. Most common congenital adrenal hyperplasia. 21-hydroxylase deficiency leads to decreased mineralocorticoids, decreased cortisol, increased sex hormones, increased 17-hydroxyprogesterone. What causes euvolemic hyponatremia in SIADH? SIADH, very common, very high yield. You will see increased antidiuretic hormone. ADH causes water retention. This leads to decreased aldosterone. You also see increased anti-natriuretic peptide ANP and increase in BNP, brain natriuretic peptide. This leads to increased urinary sodium secretion. What is heat intolerance, weight loss in hyperthyroidism? What causes heat intolerance, weight loss in hyperthyroidism? Basically, you have increased sodium potassium ATPase. Increased sodium potassium ATPase. Increased sodium potassium ATPase leads to increased basal metabolic rate, leads to calorigenesis. Myxedema in hypothyroidism. Myxedema in hypothyroidism is caused by increased GAGs in interstitial space, causing increased osmotic pressure, increased water retention. Next condition is Graves' ophthalmopathy. Graves' ophthalmopathy is caused by lymphocytic infiltration and fibroblast secretion of GAGs. Glycosaminoglycans increase osmotic muscle swelling and inflammation. Next condition is primary hyperparathyroidism. Primary hyperparathyroidism caused by parathyroid adenoma or hyperplasia leads to parathyroid hormone. Secondary hyperparathyroidism leads to decreased calcium or increased phosphate, leads to parathyroid hyperplasia, increased parathyroid hormone, increased alkaline phosphatase. Next condition is vascular disease and diabetes mellitus. Non-enzymatic glycation of protein, which is small vessel hyaline arteriosclerosis and large vessel atherosclerosis. Vascular disease and diabetes mellitus caused by non-enzymatic glycation of protein causing small vessel hyaline arteriosclerosis and large vessel atherosclerosis. Next condition is diabetic ketoacidosis. This is because of decreased insulin or increased insulin requirement. This leads to increased lipolysis, which leads to increased free fatty acid oxidation. This leads to increase in ketogenesis. Next condition is hyperosmolar hyperglycemic state, hyperglycemia causing increased serum osmolality and excessive osmotic diuresis. This is HHS, hyperosmolar hyperglycemic state. Next condition is Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is caused by gastrinoma in pancreas or duodenum, causing recurrent ulcers in duodenum or jejunum, which also causes malabsorption. Next condition, duodenal atresia, recanalization failure. Duodenal atresia is recanalization failure. What is jejunal ileal atresia? Jejunal ileal atresia. Jejunal ileal atresia is disruption of mesenteric vessels, which is most commonly due to superior mesenteric artery SMA causing ischemic necrosis of fetal intestine. What is superior mesenteric artery syndrome, SMA syndrome? This is because of diminished mesenteric fat causing compression of transverse portion of duodenum, which is the third portion of duodenum. Duodenum has first, second, third parts. So third portion compression is caused by diminished mesenteric fat by SMA and aorta. This is superior mesenteric artery syndrome. What is achalasia? Achalasia is degeneration of inhibitory neurons in mesenteric plexus of esophageal wall, causing failure of lower esophageal sphincter relaxation. Achalasia, degeneration of inhibitory neurons in mesenteric plexus of esophageal wall, causing failure of lower esophageal sphincter relaxation. Next condition is Barrett's esophagus. This is chronic GERD causing metaplasia of non-keratinized stratified squamous epithelium to intestinal epithelium, which is non-ciliated columnar with goblet cells. So because of chronic GERD, you see metaplasia of non-keratinized stratified squamous epithelium to intestinal epithelium, which is non-ciliated columnar with goblet cells. Next condition is acute gastritis secondary to NSAIDs. Decrease in prostaglandin E2 leads to decreased gastric mucus protection. This causes acute gastritis secondary to NSAIDs. What causes celiac disease? Celiac disease is autoimmune mediated intolerance of gliadin found in wheat. This leads to malabsorption, distal duodenum, proximal jejunum, and steatorrhea. Next condition is fistula formation in Crohn's disease. What causes fistula in Crohn's disease? Fistula formation in Crohn's disease is caused by transmural inflammation. Transmural inflammation. If you see a question saying transmural, that means they are hinting towards Crohn's disease. Next condition is Meckel's diverticulum. Meckel's diverticulum is persistence of vitelline omphallomesenteric duct. Next is Hirschsprung's disease, which is loss of function mutation in RET. Hirschsprung disease is loss of function mutation in rat, which leads to failure of neural crest migration, causing lack of ganglion cells, enteric nerve plexus in distal colon. Next condition is adenoma carcinoma sequence in colorectal cancer. Adenoma carcinoma sequence in colorectal cancer is because of loss of APC, decreased intracellular adhesion, increased proliferation. Loss of APC means there is decreased intracellular adhesion and increased proliferation, which leads to KRAS mutation. KRAS mutation is unregulated intracellular signaling pathway causing loss of tumor suppressor gene TP53 and DCC. Important. High yield. Adenocarcinoma sequence in colorectal cancer caused by loss of APC, causing decreased intracellular adhesion, increased proliferation, causing KRAS mutation, unregulated intracellular signaling, leading to loss of tumor suppressor gene TP53 and DCC. What causes fibrosis in cirrhosis? Next condition, fibrosis and in cirrhosis. This occurs via stellate cell production of ECM. Next condition, Rye syndrome. Aspirin causes decreased beta oxidation via reversible inhibition of mitochondrial enzyme. Rye syndrome, decreased beta oxidation via reversible inhibition of mitochondrial enzyme. What causes hepatic encephalopathy? Hepatic encephalopathy caused by cirrhosis, causing portosystemic shunt, which cause decreased NH3 metabolism. So you have decreased NH3 metabolism. Next condition is alpha-1 antitrypsin deficiency. You see it in two places, liver and lung. LL, alpha-1 antitrypsin deficiency. In liver, you have misfolded proteins aggregate in hepatocellular erythema, and liver causes misfolded protein aggregate in hepatocellular endoplasmic reticulum. So liver, it causes misfolded protein aggregate in hepatocellular endoplasmic reticulum. This leads to cirrhosis. In lungs, you see decreased alpha-1 antitrypsin causing uninhibited elastase in alveoli, leading to pan-acinar emphysema. Next, you see Wilson's disease. Wilson disease is mutated hepatocyte copper transporting ATPase, which is ATP7B on chromosome 13, causing copper incorporation into apoceruloplasmin and excretion into bile, causing increase in serum ceruloplasmin, copper in tissues and urine. Wilson's disease is caused by mutated hepatocyte copper transporting ATPase, which is ATP7B on chromosome 13, copper incorporation into apoceruloplasmin, excretion into bile leads to increased serum ceruloplasmin, copper in tissue and urine. What causes hemochromatosis? Hemochromatosis caused by HFE mutation on chromosome 6, causing decreased hepcidin production and increased intestinal absorption, which leads to iron overload. When you have iron overload, you see labs such as increased ferritin, increased iron, decreased TIBC, and you also see increased transferrin saturation. Next condition, gallstone ileus. This is fistula between gallbladder and GI tract. This leads to stone entering GI lumen. This leads to obstruction of ileocecal valve, because this is the narrowest point of the ileocecal valve, so obstruction happens because of stone passing from gallbladder to GI tract. Next condition is acute cholangitis. This is because of biliary tree obstruction. The biliary tree obstruction leads to stasis, bacterial overgrowth, causing acute cholangitis. The obstruction is because of the gallstones.